it sounds terrible because like, what? You play computer games all the time? But yeah, computer games for me is like very de-stressing and relaxing. You can beat up and kill things on the computer and you feel better, especially if you're upset, because you just feel like the need to hit something when you're upset, and just, killing a monster or a zombie makes you feel 100% better.
What type of video games do you play?
I play World of Warcraft and Fortnite.
Hi, I'm Waveney,
And I'm Dang.
and welcome to the first installment of our series, Critical Conversations, where we tackle topics both big and small with doctors in critical care fields to find out more about who they are, what it's like to be a critical care specialist, and hopefully spark interest and passion for emergency, retrieval, intensive, and anaesthetic medicine at Western Sydney University. Today, we're joined by Dr. Josephine Tan, a senior specialist anaesthetist at Liverpool and Campbelltown Hospital, and the current head of anaesthesia at Campbelltown. She graduated from UNSW, trained in the Southwestern Sydney Local Health District, and fell in love with the country feel of Campbelltown. She previously worked as supervisor of training at Campbelltown and rotational supervisor of training at Liverpool. Outside work, she enjoys playing computer games, keeping chickens, and living sustainably.
Welcome, Dr. Tan.
Thank you, Waveney.
Alrighty, so to kick us off today, our first question, I feel like this is the easy question to get us started, is why did you choose anesthesia?
Um, I guess it's like the easiest and also the hardest one. So when you're at med school, we all think, what do we love about medicine? And, a lot of people talk about ER and, the excitement of ER. If you like critical care, then ER is like emergency department is really exciting. And you sort of think, oh yeah, ICU and anesthetics are a little bit part of that. So I did initially want to be an emergency, like do emergency, because I really like the fast-paced stuff. But after I did anesthetics, I really liked the procedural stuff. So, and I just liked the idea of being able to work with surgeons and just the physiology and pharmacology of it. Yeah, so when I did anesthetics, I was quite good at it. I quite liked it. I felt like I was learning a lot, and I decided that I wanted to pursue that probably for my resident year. So as an RMO2, I did an anesthetic term and I loved it, and then I started going down the critical care pathway towards anesthetics. So yeah, so now that I'm there, it's a little bit different to what I thought. So we all think, oh yeah, anesthetic is cool. We do really difficult things, but there's so many things in anesthetics you can do. One of the things that people don't realize about anesthetics, I guess they sort of do, but they sort of don't, is that you can actually work as much or as little as you want. So that's a very attractive part of it. So I could work, well, sometimes I work 5 or 6 days a week. A lot of my friends also work 2 or 3 days a week, or those who have children, have a lot of family commitments, can even work 1 day a week. So in terms of that, it's actually very flexible in terms of lifestyle, which is really good. The second thing which I find really good about anesthetics is that we work in a hospital setting, and I like working in a teaching hospital, and I love teaching because anesthetics is a really teachable profession. So there's lots of skills which are like advanced skills that you can teach to students, you can teach to like registrars, and you can teach to other consultants who don't do the specialty as much. And we can subspecialize within it as well. So there's little interests you can have in anesthetics, which I find really fun. So we all have our own special little things in anesthetics that we like to do. So yeah, so
Yes,
that's why I love anesthetics.
that's awesome. That's a lovely little pitch. You mentioned that you do quite a bit of teaching. You enjoy working at teaching hospitals. Naturally, that's probably part of the reason why you're working so many days a week. But in terms of the most rewarding thing that you do as part of your job, can you narrow down what that is?
In terms of, let's say in terms of the anesthetic part, I think I take great pride in when a patient's really happy with the outcome of their anesthetic. Like patients are so anxious when they come and then they see you and you're about to stab them with needles. They don't know what's happening. If you just talk to them, they feel reassured. You feel much better at that. And then if you do surgery and everything's perfect in their surgery, the patient's comfortable when they wake up, not in too much pain. All of their, like, let's say it's a cancer, or their cancer's been removed, like everything's gone well and they're ready to go home and they're so happy and comfortable and, you know, family's happy with the results, you feel really good about that, and it's really nice when the patient says at the end that, I had a really good experience. It was really good. Thank you for making me feel so at ease. That just makes me feel really good. It's always nice when you feel like you've done something really good for a patient. Obviously, not every day is like that, but when you have days like that, you just feel really great. So I think I aim to have my anesthetics all go like that, so you feel good every day.
That's what we want, hey.
Yeah.
But if you weren't making sure that patients weren't totally at ease in everything and you weren't running around both Campbelltown and Liverpool hospitals, what would you be doing with your life if you weren't, I think, doing medicine?
So if I wasn't doing medicine, I think I'd like to do something more creative. It's like, I think for me, I've always done medicine because I like helping people. So I've never gotten to do charity work. This sounds really stupid, but I haven't done any charity work because I'm just too busy working. So I would love if I had less working time to do something more charity like, like I would like to like go to like a nursing home and like, talk to old people. And just because I do a lot of talking to older people anyway, it'd be just nice to have for them to have company. I like that sort of thing. I'm probably not, I wouldn't do any of those food things because I can't cook or serve anything, but that's not one of my specialties. But talking is one of the things I'm really good at. And I think a lot of people don't realize how much talking improves everything, improves your life in terms of connection to people and just your happiness overall.
What's the most powerful story you have of where communicating with a patient has made a situation that was potentially really scary or disastrous for them turn out much more smoothly?
Okay, so this is tough. I think let's say the hardest conversations would be those who are actually very unwell and they need to have some kind of risky surgery. You know, I had a patient who, okay, so this is, I think, I'm not sure if it would put some communication, but it felt like I had a big role in
Sure.
this patient's care. This man he had a head and neck cancer. So he had laryngeal cancer. He had just retired. He was looking forward to his retirement life. He wasn't that old. He didn't smoke, didn't drink. It's unfortunate he just had head and neck cancer. And I think once he found out his cancer, he pretty much didn't want to live, but his cancer was actually curable. If you have a head and neck cancer, you will need to have a laryngectomy. It is quite deforming because you can imagine not having a voice box, having to have a trachea all the time for the rest of your life, never being able to speak can be quite daunting, especially what does that mean for my life? But he will actually live and still have a life. He'll still be able to eat. And he actually can do a few things that he just can't talk or anymore, but his day-to-day stuff, if he actually loved to raise chickens, so he could still do all of that if his cancer surgery was successful. So he didn't want to have the surgery. He said he'd rather just die of his surgery. However, I tried to talk to him about what that would mean. I said, your health is actually very good. You can still do all of these things. If it was me, I would have this surgery. If it was my family, I would have this surgery because they would still live a good and happy life. I said, just because you don't have your voice box anymore doesn't mean you can't still be there for your family. You still can see your kids and grandkids grow up and you can still enjoy all your hobbies. Just you won't be able to sing anymore and you won't be able to talk as much anymore, but you can still communicate with your family and do all your normal things. You can still see, you can still hear, you can still attend movies, whatever you like to do. So he went away and thought about it. And he came back and he had his surgery. And I saw him at Liverpool having his surgery, and he was very grateful. Like he was scared obviously because he'd had his surgery. But after that track, his family was very grateful that we'd had this conversation. Surgeons have these conversations, but I think from the human aspect, if you just add a little bit of, I would do this for myself, I would do this for my family, and it's not as scary as you think. It's cancer. Cancer doesn't necessarily mean the end of the world and you're going to die. It can be cured, and it was nice. I felt really good after that.
That's awesome. Yeah. Alrighty. So, speaking of patients who are really struggling with the decision to make risky surgeries or commit to certain procedures, how do you deal with the end result when the patient isn't happy with the procedure or things didn't go to plan, unlike that man? How do you deal with the emotional burden of that?
So I think a lot of anesthetists deal with that. I won't just say me myself, but other anesthetists deal with that, but like it's the surgeon's problem. And I do understand that, like if it hasn't gone well. So let's pretend that it was something to do with the anesthetic that didn't go well. Like the patient woke up and it was in agony, and no matter what we did, we couldn't fix it. And so they were unsatisfied with their surgery. All you can do is support them through that. But in terms of having to deal with it yourself, a lot of people it's easy to shut off because part of the anesthetic thing is like we only look after you for the 24 hours around the surgery. Maybe that's not the best thing to do, but we do still follow them on with other people. Like we hand them on to like the acute pain service, for example, who follows the patient from day to day. But in terms of when a patient doesn't have a good outcome, the patients themselves don't mind, I think, having a bad outcome as long as it's explained to them why it was bad. Like you bled a lot and you lost a lot of blood, need a blood transfusion, you got an infection or whatever. They don't mind so much as those like explain to them what happened. I don't think patients like being kept in the dark about those things. So if you're long as there's openness and disclosure, and you genuinely look sorry and you genuinely caring about what happened to them and that you didn't do it on purpose, it's usually can feel good about that. Patients don't mind as much, though you do still feel bad when things go badly.
Yeah. And not just in communication with patients, but in communication with other members of the medical team. What have you found are really good strategies for making sure that there's still that team cohesion, even when certain things have gone wrong? And so there's the opportunity to blame people and maybe create like really bad working dynamics.
Oh, that unfortunately that does happen anyway. Look, what the best thing to do, I think, when you find is that everybody should debrief at the end. That there's going to be a lot of sadness and anger throughout, at the end from everybody. There'd be blame, thinking, why did you do that? I didn't do that. It's I think it's human nature. All you do is just like, if we get everybody together and just, powwow it all out and just talk it all out, I think that's at least to get the facts straight so there's no confusion about what's happened. That's probably the only way to make it all better when everybody's upset and blaming each other, talking it all out, getting the facts straight, and then talking about how we can do it better for the next time, even though everybody's going to feel bad after a bad outcome, but there's nothing else much you can do. So I suppose the example of that is we had a patient who unfortunately had an infection. She came in with an infection. She was pregnant. She came to theatre, had to have an emergency cesarean. Unfortunately, because of her sepsis, she had a group A strep sepsis, which is on the rise at the moment because it's not very well recognized in the community. She died of her sepsis on the table, and it was really, really sad. You can imagine everybody was devastated. The dad's here left with a new baby and a dead wife, and it was really, really horrible. Everybody was like, what happened? Whose fault was it? But I think once everybody sort of looked together, tried to support each other through it, it was a lot better. But self-blame and self-anxiety and having, your own stress, it is an important part of what we do. And you just need to make sure you have something to help de-stress it out. And talking about it is probably the best thing you can do. Try not to bottle it in because you'll just sit there and think about it. You can't sleep, you get stressed,
Yeah.
Yeah.
Apart from obviously talking about the bad experiences, working 5, 6 days a week, every day, high up in 2 hospitals, that must be a lot of work. How do you make space for yourself so that you can avoid burnout?
I think, as I said, for me, it's not an issue because I'm a little bit hyperactive and I love to do lots of things. I'm always very busy. So that works for me. But obviously for the normal person, that probably wouldn't be like that. You will probably know people who are just like on the go all the time, doing something all the time. You're like, how did they do that? So for me, I think organization is really important. So if you have your day, you know what you're doing every day. Like I like to know what I'm doing every day. So if I'm working at this certain place, I know that I've got this set out. This is what I'm going to have for dinner. This is the time I log, I've got time for myself at this time. And I sort of make my life working around that, So as long as you have a timetable and you're quite strict with the timetable, like I would say, okay, on weekends, I have let's say you have a class, for example, to do whatever. I would make sure that you have time for that class. And if you don't, you might have to think of something else you have to drop to make room for that. Whether that's going out, whether that's the extra shopping or whatever, or the run on the beach, just make sure that you have time to make sure you get that relaxed thing in so that your mind can reset to get you ready for the rest of the week. Yeah.
Yeah, and I think on that topic, you mentioned making sure you've got like dinner on the table, etc. I'm assuming that you have like relatives, siblings, parents that, do still exist even as you're holed up in the hospital. How do you make time to make sure that you're filling your emotional cup and your relationships? How do you make time for the people in your life through that?
I guess you have to think what's important to you. So you do have to, with all things, you have to sacrifice a little bit. Probably the thing I sacrificed from in my life is probably hanging out with my friends all the time. I think at my age, when everyone has their own families, you tend not to just hang out every weekend. You used to go with your friends like every second day. Oh, let's go at this. Let's go to the movies. Let's go do this and that. We just don't do that anymore. We probably do that maybe probably once every 2 months or something, where we see our friends. But because the rest of the time we spend with family. So it's me, my husband, and my kids. So my kids are quite, well, they're big now. They're teenagers, but they knew when we were little that mum and dad are working and that we always would have time for them in the evening when we go home. So I spend time in the evening with my family, with the kids, so all the time is spent with the kids after hours, and so we don't, I'm not one of those parents that, got to have mum and dad time where we just have to ourselves. We actually do everything as a family. Holidays, we go as a family. We go to the movies, we go as a family. Even when the kids were small, we'd take them to the movies when they're like 2 or 3, give them an iPad, but at least we're still together. So they never felt they were left out. And I think that bit's important. So the family we're all still quite close because of that. So their kids have never felt neglected because of that.
That's really awesome. That's so sweet that you're taking your children into consideration. I feel like it is hard. I mean, I think all of us in medicine, considering the other aspects of our life that we need to sacrifice in order to do better in our career, do have to make some choices sometimes. Apart from obviously spending a little less time with your friends, but it sounds like you're very well connected. Are there any other things that you've had to sacrifice personally in order to get where
Um, I I like writing, like even when I was younger, I used to write a blog, I used to play a lot of computer games, write about that sort of stuff. I can't do that. I don't have time for that anymore. So that sort of stuff I decided to put on a back burner, and I'll probably go back to that when the kids have grown up and those sorts of things. That's the kind of stuff I've sort of put to the side. All the other things that I think are important, which is to me important, is like playing computer games and doing gardening. That's really therapeutic, and I feel happy doing that and just relaxes me. So that is always there. I've always made time for that. It sounds terrible because like, what? You play computer games all the time? But yeah, computer games for me is like very de-stressing and relaxing. You can beat up and kill things on the computer and you feel better, especially if you're upset, because you just feel like the need to hit something when you're upset, and just, killing a monster or a zombie makes you feel 100% better.
what type of video games do you play?
I play World of Warcraft and Fortnite.
Okay, nice, nice. And with your gardening, what's your favorite part about gardening? We're going a little
Oh,
bit more style here.
yeah, so I love sustainable things. I'm not sure if it's an anesthetic thing. A lot of anaesthetists are very pro-environment, so I guess it started when I had children. So I was like, okay, what can I do to, I really wanted to use reusable nappies, like cloth nappies, just to reduce rubbish. So then I was really into doing that. And then after that, I started growing vegetables. So I thought I would just grow a little bit of vegetables on the side to, to help supplement, so I don't have to buy stuff all the time. And then I wanted to keep chickens because I could have my own eggs. And then that just, garden scraps go outside, like not garden scraps, kitchen scraps go outside. So there's less waste, less food waste, especially with kids because they don't eat their food, so the chickens will eat all their leftover rice and pasta and whatever. And then because the chickens poop so much, it's really good for the garden. So all these things just started growing, you know what I mean? So then I just like, okay, cool. So easy to grow stuff is like what I like to grow in my garden. So you just pick pumpkins, chocos, usual herbs and things, tomatoes, that sort of stuff. So yeah, I really like doing that sort of stuff. And then it's sort of very satisfying having your own eggs and veggies there.
Yeah, that's awesome. Congratulations.
Thanks.
With that love of sustainability, you mentioned reusable nappies and growing your own food. Medicine is very not reusable. It's a lot more difficult to sterilize things again than it is to just buy new ones.
Mm.
How do you deal with that in the workplace, that idea of sustainability?
So because everything's so disposable now, like we've been trying to move back to reusable. However, it's expensive. So some things we can't do, There are other things that we can do to promote environmental things. One of the things that I particularly care about is drug throwing out. So where do we throw our drugs? Like anesthetics has a lot of drugs that we just chuck out. Where do you put them? Down the sink, in the bin? If you put them in the sink, it's actually really bad for the environment. So, and you put in the bin is exactly the same as dumping in landfill. So it does leach into the ground and get into plants. So at Campbelltown, we have these little drug bins where you put drugs, which is really good. So people can't steal drugs anyway. It's good because, people could technically fish out your drugs from the bin if they wanted to. But if you put it into these drug bins, it's inactivated by like a gel. It literally looks like cat litter, like some kind of gel cat litter. Once you put it in, it just sort of absorbs it all up. So you can't use it again. And then you just dispose of it with drug waste in pharmacy. Or you can put it into the contaminated waste and gets rid of it. So that bit is one little environmental thing. We do try and use less, like try and use less things like blueies, stuff that's really disposable. Try and use less of that. Just if we have less waste, that's probably one thing that we can do, even if we can't recycle or reuse a lot of our stuff. If that makes sense. That's probably the only thing that we can do in anesthetics, other than changing some of the anesthetic gases that we use or use less of the gases. But that's like a different topic on its own.
Yeah, yeah. You mentioned that at the end of procedure, you throw out the drugs, you put them in the drug disposal. Apart from that, what does a typical workday look like for you? And I say typical, which
Yeah.
changes.
Okay, so a typical day is, anaesthetist has to be there before the surgeon. So you do start before everybody else. Operating list starts at 8. Anaesthetist really should get there by 7:45. So talk to the patient, get everything sorted, check the anesthetic machine. So that's what we normally do. So you go in there, get everything all ready. And also just remember we are the last to leave. So when we come, we're there first in the morning, setting up everything. And then by the end of the day, you try and make sure that everything's turning over nicely so that we can get home on time. So efficiency is good, but that does compromise a little bit with teaching because, teaching does slow things down, but, you can make things work. It's like if you just allocate enough time to make sure these things get done, you'll be okay. Like, give the registrar at least 5 minutes or give your student at least 5 minutes, troubleshoot them a little bit. The surgeons won't even notice because they're busy doing their own stuff, as long as it's not noticeable and it impacts on them, nobody's going to notice when you're teaching and everybody still has fun. So yeah, so that's like a typical day. So I wouldn't get home till after, like when the list is finished, usually about 5 or 6 o'clock. Probably don't get to leave till after then because officially you should check that your patients are okay before you go home. If you put them in recovery when they're asleep, you need to make sure they're going to wake up or that they're not in too much pain. And then as soon as you're happy they're awake, you can leave and go home. At the public, it's a little bit easier because you've got registrars who can do that. But if you're working in the private or something, you probably need to make sure that that's all sorted before you leave because it's your responsibility to the patient. So that's a typical day. Now, some days are busy. Like if you have a list of like 20 patients, it is exhausting. By the end of the day, you're just, or if you do a day full of kids where you're just, crying kids all day, it's actually mentally very draining, just doing drug calculations in your head for pediatric doses and stuff. But some days you do like a big case, like a big cancer case, which takes about 6-7 hours. You get a little bit of downtime, just changing syringes. Can be a little bit mundane and mind-numbing. So depending on what you do in anesthetics, you can go from like fast-paced, really busy to slower, longer things where you got more time to do stuff. And I have a mixture of all that in my practice, which is good. So it just keeps me interested. You know what I mean?
Does that change across which days you're doing practice on? Like across a typical week, what does that week look like?
Okay, let's take a typical week like this week. So on Monday, I was doing colorectal with my surgeon. We do scopes in the morning and we did like small cases in the afternoon. On Tuesday, I was at the public, so that was yesterday. So I was like, just doing like clinical work stuff. So like not clinical work, sorry, non-clinical work where I am just doing rosters, doing allocations, getting everything ready for next year. Just all the things administrative things that heads of department do and going to meetings. Today I was doing pediatrics in the morning with my surgeon, and after that I was free, so I came to the public and I'm here talking to you guys. Tomorrow I would normally be doing orthopedics with my other surgeon at another hospital. And on Friday I would be doing cancer surgery with my colorectal surgeon, which is usually like 2 big long cases, over the whole day, which can be a long day, like an 8 o'clock start, sometimes a 9 o'clock finish. So those are pretty rubbish days when that happens. But yeah. And this week is normally the week I would also work Saturday, where I work my surgeon from 7 in the morning till like 3 in the afternoon doing breast cancer cases. So yeah, that's pretty much what my work week would look like. But that is not a typical work week for most people. It just happens to be a heavy week for me.
Yeah. So you mentioned that you kind of restrict your admin days, especially in your role as the head at Campbelltown, to kind of Tuesday, Wednesday, unless I'm like losing track of where the week is up to.
Yeah, so we work on a 4-week cycle, so it's random. So it just happens to be this week I've got that. Next week, my admin day is a Monday, which is a public holiday, by the way. So yeah.
And so do you get, well, I assume you seem like a very efficient worker. Do you crunch it all out on that allocated day? Or if not, like how do you make time for the admin?
Okay. So things like meetings and things have to be done on certain days. So you can't really adjust that. So one of the important things for me is that when I work with my surgeons, they all know my role. So they know that I may have to do certain meetings at certain times. So they're usually quite understanding with that. If it's an important meeting, I probably have to pause my list and do that or get someone to cover me while I do that. But in general, I usually have Mondays as admin because after the weekend, there's a lot of stuff to do. People have called in sick. There's rosters to sort out, things like that. So that's what a Monday admin looks like. Middle of the week admin is usually big meeting day. Wednesday is full of meetings, usually like today, so there's tons of meetings that I have to attend from 7:30 in the morning to like 4:30 in the afternoon. So I find Wednesday's a bit of a heavy day when it comes to meetings. It's exhausting. People think, oh yeah, do my admin, that's easy. I said, you try sitting in a meeting. It's more tiring than doing an anesthetic.
I not to exhaust you too much then. But with oh my gosh, I've lost my train of thought here. With all that admin stuff you're doing and doing rostering and trying to figure out how to manage staffing when people have called in sick.
Mhm.
For you personally, when you're trying to take time off, when you're trying to take sick days, how have you found uh, that as an experience, like as a consultant? Has that gotten better over time? It's getting worse? What's the
Trying to,
general
do you mean handling my own sick days or handling my own self-care or handling other people's sick leave?
handling your own sick leave? So obviously it'll be a bit different now that you're kind of in charge of it at Campbelltown, but when you're
Yeah.
applying for it, what's that like?
So if when we have when you're sick, for me, I've got a responsibility to do things. Admin days are okay, but if I had a list, there's a whole bunch of patients that need covering on my list. If I know I'm going to be sick, for example, if I have let's go back to a few years when there was COVID and you got COVID, you had to be off for the whole week. So you need
Yeah.
to you'd probably call your friends, say, hey, are you busy? I need someone to do this for me. So you find your friends to help cover you. If not, if you're the public, usually they can find someone to help cover for you because for sickness, we try and help out each other as much as possible, which is why I like working at Campbelltown. Everyone at Campbelltown is always so helpful in terms of helping people cover when they're sick. So I like it here because of that. But that's pretty much what it's like when we have sick call here, because it's not just like, oh, we're going to call in sick. What's going to happen? It impacts all our patients. The patient has been fasting for surgery. They've taken the day off work. They've had a family member have to bring them into hospital and take a day off work to help take them home later. If we call in sick and they get cancelled, it's like I feel so bad for the patient. So we try and make sure that we find someone else to cover us to make sure that everything keeps flowing.
Sounds like a bit of a logistical nightmare, but also something that seems to get sorted out because everyone's still having their surgeries. In
Yeah.
terms of now being the head of anaesthesia at Campbelltown, did you have to do any additional training in order to do that position? Did you how did that becoming that admin role work?
So I've done admin things for a while. Being a supervisor training and doing, those sorts of rostering type things for like rotation supervisor, you sort of get an idea how the hospital works. Um, and then so like for recruitment, all that stuff you sort of learn it over the years. But when being head department is actually a big step because you suddenly have to run a business meeting, write business cases, have meetings with executives to report budgets. It's like, oh, what do you do? All you can do is like, I didn't have training, but there is training options that you can do on HETI and stuff like that. And obviously you can ask people who have done it already to help you. So you can ask them how they do it. What should you do? And that bit helps. And eventually you find your own style. Everybody has their own leadership style or leadership goals on how they want to run something. So yeah, that's pretty much what it's like. I think if you want to be a leader in the future, I don't think, to be honest, I don't think anybody wants to be a leader at a head department. They'll go, what? Are you crazy? That wasn't my goal as an anesthetist. I finished training. I'm like, oh yes, I'm going to do obstetric anesthesia. I love doing pregnant ladies. And, I find obstetrics really satisfying, having when they're also scared because they're going to have a baby, then they have the baby, everyone's cuddling the baby. It's always so happy. It's a really great part of anesthetics, from my opinion. But imagine I just went from doing that to doing all this. It was like, no way, I wasn't going to do that. But as time goes on, I think we all grow as people. And after a while, you feel like you need something to challenge you. And for me, this is like a new challenge, which was not expected, but I don't hate it.
Apart from this role, sorry, my voice is going. Apart from
That's
this
okay.
role, what other aspects of your job have you specifically chosen to give yourself a challenge and keep that kind of spark and that passion for anesthesia alive?
One of the things I like doing, probably because I was a supervisor training, I really like mentoring my trainees, and I'm really pro home growing like trainees. Campbelltown is typically and Liverpool have been typically hard to get people to recruit and stay in. But now that Western Sydney is out here, we find it easier with access, having students that we can teach and who live locally and grew up locally. Tapping into that for me is really good because they're people who want to serve their community, who grew up here, and if you encourage them and show them how much fun it is and how great it is and how happy we are, we're hoping that will bring them into doing critical care at Campbelltown, if that makes sense, Like
Yeah.
when I was at med school, everyone wants to go to RPA, North Shore and Prince of Wales, and that's fine. But I'm I'm from Canberra originally, and I've always lived, I always worked at here, and I really like it here because I find this challenging, rewarding. I feel like I'm doing medicine. So if there are people who are like that as well, I will just, as soon as I find out they're like that as students, I try to encourage them to do more and, encourage them to talk to me. So I usually have them all talking to me if they want to ask me anything about anesthetics, if that makes sense. And for trainees too.
What kind of personality traits suit someone in critical care and especially anesthesia?
Um, in critical care in general, you need to think quickly on your feet. So those who can think fast and don't get paralyzed, those do best in critical care because, the seconds count. And I know everybody gets scared. It's when you know what to do, it makes it easier. And just practicing all that is what we train for. But if you're somebody who isn't afraid, who isn't going to get stressed out by that sort of stuff, then critical care is suited to you because you will see dying people, bleeding people, vomiting people, all sorts of scary things. If that sort of stuff interests you and doesn't frighten you, then critical care is suited for you. You know what I mean? So yeah, that's what I recommend. If you're somebody who goes, oh, I don't think I could handle people dying and have to do CPR at least twice a day or something, probably critical care is not the thing for you. Yeah, because you might find that too much of an emotional overload. Does that make sense?
And you mentioned being able to trust yourself in your decisions even when you're scared. As like a bit of a follow-up question, how long did it take you to be able to trust yourself in knowing what to do?
As an SRMO, when I moved straight from being a PGY2 into an SRMO, you started having to do met calls by yourself. I still remember for the first 3 months, I was literally going in my head, A, B, C, running through the thing in my head and thinking, I don't want to make a mistake. But after a while, it just becomes, you do it so much, it just becomes numb. You just turn up, you take the airway, you do all the checks, and just check for pulse, start CPR, blah. That sort of stuff just comes after practice. It doesn't matter if you don't know it at first, but if you do it enough, it will come to you. So yeah, I won't say that you have to sit there and memorize and practice it all the time, but if you see, like, even if you're just walking on the road and if you see something, you think, okay, what would I do if that happened? And you have an idea what you're going to do in your head, it makes it easier for you when it actually does happen.
So I think kind of building on that, what do you want your future fellows to look like?
In future fellows in anesthetics?
Yeah.
Yeah. So in this department, I've been trying to promote more team things where you all work together and help each other. It's actually more of I think in the last 5 or 6 years, people tend to be more individuals, like, working for me, what's in it for me. I just want to turn up to, I just want to turn up to work and do my job and go home. Is a very common theme in medicine overall. So I tend to encourage my trainees when they're coming through, if those who have encouraged, who have that sort of spark about wanting to do a little bit more, I always try and encourage it. There are some people that you might know who just love organizing things, so then I just encourage them to help organize things, like whether it be like a get together with the trainees or help organize lunches for the department. These little things actually must make the department much better and more fun. You feel more closer, and when you feel close and you belong to something, people want to be part of it and less likely to want to just turn up to work and go home, if that makes sense. So yeah, that's the kind of thing that I hope my future fellows will keep going on with, because that's what I try and do now.
That's such a lovely answer. And you mentioned obviously there's a bit of a culture change there with especially trainees thinking more about how their training can serve them, which is neither here nor there. What other, or is that the most important change you're seeing in clinical practice? Like what is happening that means that what you're doing actually in procedures is evolving over time?
I think, look, I think this is hard and this is challenging for anesthetics in general. I can't speak for other specialties, but a lot of people in anesthetics don't want to do certain things anymore. Like one of them is pre-op assessments of patients. Like that's part of anesthesia, but in the last 5 or 6 years, nobody wants to do that anymore. Yeah, I know you're looking, it's like, what do you mean? But when people just hate doing the clinic, but it's really important. We have to have patients going to the clinic, and how do I find people to do that? So I'm just trying to make people feel like everyone has to do a little bit of something to contribute, even if you don't like it. You can't always have everything that's great. If you want to contribute something, you have one little thing that's not wonderful, but you still have all the great things to come with it. The little bit of good comes with, a little bit of bad comes with the good stuff. Some people still love the clinic, but it's very few and far between. So the only other way to make these sorts of things work is to make sure that if you have to do something that you don't like, that it's cushioned with something that you really do like to make up for that.
Like when you hide veggies in brownies.
Yeah, like in your veggies, right?
Yeah, literally.
Keep up with fries, but then you can have your Wagyu steak.
Yeah. In training colleges, and also I feel like in the culture of anesthesia, what do you feel like the training colleges and what do you feel like current consultants can be doing to, I don't know, I want to say make the cultural change they want to see happen? But that's kind of a bigger, more difficult thing to establish than just saying it. What do you feel like you can be doing and training colleges can be doing to be prepping these people for what they're going to come into, which is a world that won't necessarily be what they're expecting or what they want?
This is really hard. The college, the college itself doesn't accept change much. And, it actually is very hard to change culture overall. Like, I think as a normal person who's not in a leadership role, you often feel like you don't have a voice. Does that make sense? But if you are always having a voice rather than keeping quiet, I think then eventually you'll be able to make changes happen. They don't happen quickly, but changes will happen slowly. And if you just keep sticking to it, even if it's difficult, you just keep sticking to it, it will happen. Well, that's what I find happens for me. So, it takes like 10 years to change the culture of a department. with constant, you have to set an example as well. You can't want something and then you don't do it yourself. Does that make sense? You can't expect people to contribute if you don't contribute. So if you want to make a change, you have to be that change. Does that make sense? That's probably the best advice I can give for having a culture change. So yeah.
What's been the hardest part of being that change when you're tired and you're just trying to get theatre done and you just want to go home and see your kids?
I think the hardest part is thinking, why am I doing this? That's the hardest part. Sometimes you just feel the whole world is against you. Sometimes you have to make a hard choice. You don't like the hard choice, but people don't like that. But you have to stand up for the patients. You have to stand up for, you have to stand up for something that you believe in. And that can be really hard sometimes, for example, let's say you're doing a long case, right? And the people want to say, I want to go home. And I get that. I want to go home, but then who's gonna look after your patient? You can't just leave them there, Is it fair for the consultant to leave the registrar there? No, that's not fair either. It is our responsibility as a patient and we should accept that responsibility, and trying to force that is kind of hard. It does upset people, but that's just an example of something that's really hard. You feel bad. I feel bad when I force people to do things and they get angry, and then I feel bad about they've gotten angry at me because they feel that there's no goodwill, So one of the things I find that if these sorts of things do happen, because people do get tired when they have to stay back and do things, if I acknowledge it and say thank you or do something in return, as a head department, you can do these things. Like if they had to work late one day, you go, oh, okay, look, the next day you say, hey, look, your list is finishing early. Let me help you. We'll send the registrar to help you finish your list and you can just go home early today because you had a really big day yesterday. People just love the fact that you acknowledge they had a big day and that they're being appreciated for it, and I think that acknowledgement goes a long way for somebody who's a leader, to just acknowledge your staff and help them realize that I've seen you working. You haven't been forgotten. It's when you're forgotten and ignored, you just worked like a dog, you don't feel appreciated and you lose your heart to put into that you're putting into your work. Does that make sense?
It's so wonderful that we have someone who cares about these things in charge of our anaesthetic unit. It makes me go, oh, next surgery I'll come to Campbelltown Hospital. But in terms of not just caring for our staff, which is obviously very important, but also caring for our patients, what developments in anaesthetic practice, what research are you or your team, because you're a busy person. What are you guys involved in that means that patients can feel more valued by their anaesthetist into the future?
Gosh, there's so many things that we do that, we haven't really thought about as improving for the patients, but some of the things just changing our anesthetic practice to make them feel better when they wake up. So in the old days, we use a lot of gas. Gas does make you feel a bit queasy. And then it was normal to stay in hospital for a day or two to recover from your anesthetic and then go home the next day. Nowadays, we're sort of using different anesthetics, which actually make you feel like using, well, you might not know, but using propofol actually makes you feel easier to wake up. You don't feel as hungover. You actually feel pretty good. And if you've got good pain relief, you feel like I can actually go home, on the same day. And though people may think, oh, you're just trying to kick us out of hospital. No, we're not trying to kick you out of hospital. You always do better when you're at home with your own bed, your own TV, your own family around you, rather than all these sick people around you who've got like MRSA or like, who have got dementia or something and they're screaming all night. You don't get a good sleep. People forget that, the best place you recover is in your own home. And so we do like to promote like day-only surgery and making patients comfortable so they can go home the same day. And at Campbelltown, we try and do a lot of that we only do small surgeries anyway, not anything big, but like ordinary surgeries like laparoscopic cholecystectomies, hernia repairs, even tonsillectomies, and sometimes even appendixes. We're going to try and get them to go home the same day as long as they're comfortable. We try and aim to get them home the same day so they can be looked after and have a nice time checking out the Netflix instead of relying on hospital Wi-Fi.
Well, you've mentioned the Wi-Fi. You've mentioned trying to make patients feel valued while also getting them out of the hospital as quickly as possible. You've mentioned staff having their own things going on. What is the most difficult thing about being a head of department, and how do you handle that?
The most difficult thing about being a head of department is having to have the difficult conversations when people don't perform well. Nobody likes to be told they're not doing well, and it is hard. You have to pick your words carefully. And you have to do it in a way so that they don't feel like, oh, well, fine, I'm just going to leave. You know what I mean? Because if you think I'm crap, I'll just go. So you have to think of how you're going to word things, how you're going to encourage them to be better, as well as, focusing on the things that they do well so that they want to stay. I find that bit hard. I hate giving bad news to people about them not doing well. It makes me feel crappy. Nobody likes that. So yeah, I find that is the hardest part of being a head of department, just that part of it. People often ask me like, why do you do that? I don't think I could handle dealing with all this stuff. It makes me upset, it makes me depressed. And I said, if you have children, do you love changing nappies? Do you love staying up all night? And do you love like having crying nonstop and, sore back from carrying a child around, or being pregnant and just like waddling around and you have to go to the toilet every 5 minutes? No, nobody loves that. But there's all this good stuff that comes with having children. You get a little baby to cuddle, kids come up and giving you, cuddling you at night. It's such a nice feeling. There are good things and bad things for all of them, and they will make up for that. So you can do good things as a head of department, which make you feel really good, and that makes up for all the crappy things that you have to put up with as well.
It sounds a little bit like your department is an extra child for you.
It is.
Speaking of like, children and inheritance, what kind of department do you want your successors to inherit?
I wanted to inherit a department where everybody feels valued and everybody has a place. So, and everybody gets along. Now, the difficulty with that is you don't want to create cliques where people don't feel included. You need to make sure there's a bit of everybody in it. So there's not like just one type of person, they all get along, and then have to the exclusion of others. So you need to have a broad department where everybody feels a part of something. They can feel part of, like, they can feel comfortable just being on their own and not having to say anything, but still feeling like they belong. So that's the kind of department I want. And I want trainees who encourage them to have trainees who care about their colleagues, the other registrars, and help them out if they're struggling. And also, I guess that the consultants are doing the same. When the consultants are having difficulty, I would like them to be able to support the consultants who are having difficulty as well.
Speaking of support, what do you think that doctors, both trainees, consultants, everyone in between, what do you think they can be doing to better support each other?
I think understanding and tolerance is one of the things which I think is one of the things that we don't do very well unless you've actually exposed to yourself. You sort of think, oh, yeah, I'm pretty tolerant. But I'll give you an example. In my department, we have people who've had opiate addiction issues, so that's obviously a big stigma in medicine, especially in anesthetics. We handle S8s and S4s all the time. So people automatically think if you took drugs, you are a bad person, you're a drug dealer, you're weak. You know what I mean? This sort of and that is just normal. I understand that people think that because that's what we've always thought, because, I wouldn't take drugs myself. But there's a lot of things that happen with somebody who takes drugs. They could have been in pain themselves and got addicted. They could have been stressed. Somebody could have died. Maybe they couldn't sleep at night, or, something stressful happened at work and they couldn't sleep, and then they started taking drugs to get to sleep, or, like people drink to get to sleep. doctors are human and they do make mistakes, but unfortunately, once you make a mistake, sometimes people think it's unforgivable. And trying to get people back on track, if they genuinely want to get back on track, they should be given the opportunity to be able to get back on track. Like a second chance sort of thing. But those sorts of things are few and far between. Like if you always just dismiss people, then they will never get better. It's kind of like being a criminal, I guess, rehabilitating a criminal. You can rehabilitate doctors who've been sick as well. And they can return to normal functioning society because they just made one mistake. So I think as a head department, I do see those sorts of things and people can recover from them. I think people just have to realize that lots of things you recover from. If you can recover from cancer, you can recover from depression or addiction just as well. And that's the hard part. That's really hard, actually, for most doctors to get their head around.
That's a really inspiring message. Thank you, Dr. Tan. We had one last question, which is, we're med students, naturally. We're not quite consultants yet. Do you have just one piece of advice for all med students? This can be related to what we've been talking about. It can also just be your own special, like deep in the back of your mind. What's your word of wisdom?
As a medical student, pretty much you have to be like a sponge. You sort of like soak up everything that people tell you. And then later when you squeeze yourself, some of the bad stuff just comes out. Does that make sense? So just listen to everybody tells you and eventually you'll find what's the best things that work for you. Don't take everything everybody tells you as gospel. There are so many doctors with so many opinions. You can learn from all of them and you just find which fits you. Does that make sense? People will tell you many different things, but it will take you to figure out what works for you. So as a student, it's your job to listen and learn and try and figure out from all that which bits are going to work for you to suit your practice, your personality, and your goals in life. That's what I would recommend. So as a student, all I did was like listen to everybody. I hardly spoke. I just listened, tried to learn things and figure out which things are important, which things I'm going to use, how I'm going to change my practice. Only when I was a consultant did I start talking. If that makes sense, Yeah, because I literally didn't know what I was talking about as a student.
Yes.
So
Thank you so much, Dr. Tan.
No problem. Thank you for inviting me to speak today.